opportunity, and good afternoon, everybody. So from the legal and ethical aspects of Avastin, we'll now shift to the psychosocial issues of any anti-VEGF for that matter. When you get pregnant, it's quite easy. You have a book to know what you're actually going to expect, how it is going to pan out, and what is going to happen. But unfortunately, for anti-VEGF injections, we don't have any such guidebook. But we do try our best to tell our patients what they have, what sort of a condition is this, why they need this treatment, and what this treatment is going to do to them, how it is going to make them better, what amount of visual gain, etc. they can expect after the treatment. And I'm sure everybody will always say that you need more than one injection, the frequency of injections, the average number of injections they can expect, and also the rare cases of failure of anti-VEGF treatment and switching to steroids, etc. And important but serious adverse side effects. But patients, unfortunately, when you talk all this, it just goes through their head. I just sat down and wrote what all my patients responded over the last couple of weeks. First, when I said you need an anti-VEGF injection, so the patient asked me, so doctor, there is no problem with my eyes. This is the first question most patients ask me. And another subgroup think you can only develop a cataract in the eye. So they ask me, so I don't have cataract, right? I don't need surgery. They're very delighted the moment you say you need an injection. And there's another super optimist group which think the injection is going to cure everything they have, including the prostate. And diabetics think it will cure, they're saying, okay, giving me injections for sugar in my eye, so will my blood sugar go down as well? This is a very common question. And you also have the pessimists on the other extreme. You tell them you'll need more than one injection, you have to come every month, I'll see you, if you need another injection, I'll give you an injection. So he says, so do I need to come every month for the rest of my life for injections? And there's a super pessimist who think that the condition is inoperable or untreatable. Why is this? Why is this disparity between what we tell and what they understand? Lot of reasons. First, they're anxious. Any patient advised something is anxious. Second, what I realized is there's not much of peer info. When you advise a cataract surgery, the patient has heard of that procedure before. He's heard his relatives, his elders, his friends undergoing this procedure, so he knows what it is. This is not something which it is catching up, yes, it is coming up in a big way, but it is still not that prevalent in the society that almost everybody has heard of this being done to some friend or relative. So there's no peer info. So when you tell something, he asks me, do you need an injection? Right inside my eye, he's shocked actually. And we also tend to oversimplify issues a lot of times. We tell it's a very simple injection. It's just take 2 seconds. You can walk in and walk out. So we oversimplify initially only to be confronted by the patient, doctor, you said it's so simple and it's like this and all those things. And well, cost always plays a role, and any human being, and Indians in particular, we always think the more it costs, the better it is. So patients always are misguided thinking that the costlier the drug, the better the efficacy. The costlier the drug, lesser the re-injections needed. The costlier the drug, the better the visual outcome. So that is something we will have to tell the patient upfront, that if you're going to give, say for example, even a Bevacizumab, ranibizumab for that matter, a biosimilar and the actual drug, we need to tell him, and my experience, or at least in studies, how it works pretty well the same. So a lot of issues, psychological, economical, non-adherence, repeated injections, they stop coming at some point of time. And one thing which we never look at, the quality of life, we only check vision. Before the treatment, if your treatment doesn't do well, and if your treatment does well as well, and systemic control. So almost every fourth patient who is actually receiving an anti-VEGF injection is depressed. Clinical depression according to the WHO definition. So this is because all anti-VEGF injections can cause anxiety, and it is a stressful event, especially in the beginning of therapy. And with therapy, if they are doing well, probably the anxiety and stress levels come down, but if they don't do well, then probably it again increases. And this is a study about patients, about diabetic patients. They compared patients with retinopathy and patients without retinopathy. And they realized that patients with retinopathy, for a multitude of reasons, including progressive visual loss, they tend to get negative feelings, especially about diabetic retinopathy and even about their own diabetes. They think it is slowly killing them. Economic issues, I can keep going on and on about it. So this is actually, I'm going to keep it very short. We all know the cost of all injections, starting from 8,000 up to 50,000. I always think of an example, a software engineer, so earning around 1.5 lakhs per month. Annual income will be around 18 lakhs, post-tax, etc. All these things he'll take home around, let us say, 1 lakh a month. Assuming his elderly father has bilateral AMD or bilateral DME and needs multiple injections. So we are looking at least 5 lakhs of his annual post-tax income taken away. And it is in that remaining 5 lakhs he has to care for his family, his children, his other expenses, and also invest for his future. So we're almost going to take 50%, and I'm talking of somebody earning 1.5 lakhs a month. This is very, very uncommon, probably less than 5% of India's population. When 46% of the country is below the poverty line, which is less than 72,000 a year, you can imagine what and what not they can afford. And we also only look at the cost of the injection. There's something called a cumulative cost of a visit. It is not only the injection, it means coming to your clinic, your consultation fee, your OCT charges, and the to and fro charges for the transport, and more importantly, it doesn't matter what that 65-year-old is doing. He may be sitting here, retired and sitting at home. There needs to be somebody accompanying him who comes with him, wastes a day, and a lot of times if he's working somewhere, it's loss of pay. So this is a cumulative cost of visit. So 10 to 12 cumulative visit costs will be much, much more than what actually the anti-VEGF itself costs. And other thing we need not forget is the overall cost of therapy. These people have diabetic retinopathy. They also have diabetes and other multitude of other systemic problems like renal failure. So they'll be spending in thousands for it every month as well. Non-adherence. Patient starts, comes 1 or 2 injections, then stops coming. Very common, much more common in diabetic retinopathy as compared to AMD or BRVO for a lot of reasons. But all the reasons are mainly patient associated rather than anything else. There's always a continuous increase in non-adherence. I mean, the longer you treat, more people drop out. And there's a steeper increase of non-adherence in diabetic macular edema as compared to other conditions. Non-adherence is much more common when patients are much older, meaning they find it difficult to come for repeated visit, and also when they have a poor vision at baseline, which also means the vision recovery and the results which the patient expect and what we give is not going to match. So much more poor baseline visual acuity, much more chances the patient is going to drop out. And on the contrary, if the patient improves, it is usually these patients who actually keep coming every month. You keep doing a scan and you keep telling them he has a dry macula. Those patients actually come back. The patients where the macula doesn't improve, those patients are the ones who drop out. And quality of life, something which we don't look at. This study is about both the visual quality of life and the health indices. So they used 2 questionnaires, the National Eye Index Visual Function Questionnaire 25 and also SF36, which looked at general health. So they looked at patients who underwent anti-VEGF treatment for DME alone, and the DME subsect actually had the lowest score for general health, meaning it is not only the vision which was poor, those patients had the poorest score in general health score as well. And they were the most dependent patients both vision-wise and physically in the whole study. So vision does have a big, big impact in life. That is the conclusion, actual conclusion of the study. And this is another thing about the positive side. Patients treated and who respond well. This is from the RESTORE study, it's a subgroup analysis. Patients who responded well actually had a much better improvement both in the visual function questionnaire and in their general health. So once they improve, they start feeling better with themselves, they're able to manage themselves better, they're able to take their general medications better. So it is an overall quality of life index does improve. Similar studies from the RISE and RIGHT trial as well. There was a good mean change of the composite VFQ25 scores, and it improved up to even 1 to 2 years in the treatment group compared to the sham group. So it is not only about vision, and as I said, also about general health. Another study implying that the general health, vision, near activities, distance activities, everything significantly improves when the treatment outcome is much positive. Okay. I'll just skip for want of time. And last thing, another thing I want to say is about systemic control. A lot of times, especially in DME, we keep injecting. We keep injecting every month. But I think we should make it a point every month to document how the glycemic status is, because without control of glycemic status, none of these injections are going to really work. So this is just one study I've quoted. There are numerous things which you can say, where the levels of HbA1c correlated highly with the number of injections needed and the visual outcome as well. So we saw a lot of things. It's not easy to tell every patient all this, but we do need to. So that is why our chief instructor has come up with a book on what to expect when you're injecting. It is available in JP Brothers, right, Uni? Tomorrow morning you're releasing it? Thank you.